we will recognize the utility of advanced neuroimaging in furthering HIE research by modalities mainly such as MR thermometry and cerebrometabolite analysis. This is done through MR spectroscopy. Number 2, we will describe the differences in short and long-term outcomes when performing whole body cooling by either the esophageal or rectal temperature monitoring. And lastly, there will be a potpourri of information that really, hopefully convinces you that HIE is quite complex as a heterogeneous disease in timing, pattern, and severity of injury. The first part will be really focused on modulation of brain temperature, therapeutic hypothermia to achieve neuroprotection. Are there still opportunities to further optimize this modality? And very quickly, a background slide. In the 1950s to 70s, there were already human trials that looks at
really busy. He used to make like a big thing of chicken noodle soup or soup for the week. He was like super busy.
That looks at enrolled neonates
boil it for like 10 minutes.
Sorry, Wu. Can you please mute your online login?
What's that? Sorry. Okay.
So sorry. I'll get the mutes for you. Sorry about that, Tai.
Okay. There are already human trials back in the 50s to 70s. I just wanted to share one trial here where they enrolled infants that had APGARs less than 3 at 5 minutes of life. They would, undergo intubation. Back then, they gave bicarb glucose, improve pH, improve energy delivery, and then perform CPR. And their intervention, or the research intervention, was actually immersing the infant in a cold water bath, and then continuing, bagging until the spontaneous respiration resumes. Remove the infant and measure the rectal temperature, and then go through a passive rewarming. And this is sort of the slide that shows you back in the 50s, 60s, this was already being done. Baby being dunked into a water bath that's cold. When they do come out after 5 minutes or so, that's the average time. Their rectal temperature does coincide with our target temperature these days. It's usually 32, 33 degrees Celsius. So this is just a graph that shows the initial APGAR scores, having these babies immersed in cold water, 10 to 15 degrees Celsius. The improvement in APGARs, bagging the baby in cold water, and then recovery through passive rewarming. And, very small trial. They saw very good outcomes. Any sort of neurological sequelae was only 3%. So excellent outcomes in this small trial. And this is just another slide that shows you in Russia in the 80s, they were doing something very similar, trying to cool down the brain during, asphyxia, if there are any events of asphyxia. Then in the 60s, 70s, again, there's a counter focus on normothermia, as we found out, by Silverman's landmark trials, that there's improvement in survival when preterm infants were cared for in more temperature regulated environments. And so a lot of these trials moved away and went to normothermia even during resuscitation for term babies. And I think that's a lesson to be learned. I think we often apply what we do for preemies to term babies. They can be quite different. There was renewed interest in the 1980s. This is by Busta Rao. They were doing rat experiments, exposing their brains and doing histopaths. And for some reason, the operator for A always had better histopath, less cell death than the operator in B. And later they found out that, operator B often used a heat lamp because he couldn't see very well and during his dissections. And that really rejuvenated, this hypothermia and neuronal preservation idea. A big landmark study by Alistair Gunn, which brought us the fetal lamb and utero asphyxia model. Adding inflator occluder cuffs around the carotid arteries and utero and fetal sheep, and then occluding flow sort of creating this asphyxia in utero model, and also starting cooling therapy in utero, having this cooling coil around the scalp. And this is just a very nice demonstration of histopath showing neuronal rescue of hypothermia. You can see with head cooling, the preservation of the neuronal loss is much less than the white bars. And this led to a number of large randomized trials in multi-centers, either head cooling or whole body cooling. And now it's become standard of care. In this modern era of therapeutic hypothermia, still about 40% of newborns will die or have moderate severe disability. So I think in the past 15 years, there's always been an urge, a impetus, and sort of a race to find that other drug that would work and complement well with therapeutic hypothermia, be it xenon gas, melatonin, just a list on this page, and eventually maybe getting to some form of cocktail therapy. And unfortunately, nothing's there yet in prime time for us to use as standard of care. So while I was in fellowship, to me, there were unresolved questions in terms of, what the brain temperature profile is like during cooling. How cool is this target organ brain? And are all brain regions equally cool? How else can we optimize cooling itself? And what's the impact of brain temperature on cerebral metabolites? A quick background on the physiological determinants of brain temperature: heat generation by cerebral metabolic rate, and then heat dissipation by blood flow carrying away the cool blood, with arterial blood temperature being sort of the background. And then, of course, the scalp temperature and the physical environment. So a little bit background again here for brain temperature in a pathological state. You can see this is a DWI image for adult acute ischemic stroke, left MCA stroke. And in stroke and traumatic brain injury, brain temperature can be elevated above the rectal temp. And this is sort of a heat map using MR spectroscopy to derive temperature maps. And you can see that area of stroke is on the ipsilateral side is higher in temperature. And that elevated body or brain temperature has been shown to be associated with poor neurological outcome in setting of brain injury. Medications, sedatives, analgesics may also alter brain temperature. And just 2-3 slides to review MRI basics so that we can, try to understand how can we actually measure brain temperature non-invasively. And it really felt like black magic to me initially. How do you go from a big magnet into making it a big thermometer? And when you land an MRI, there is a background magnetic field, B0, that really aligns all the protons. So they're all pointing in the same direction, in this direction in black right now. And then a magnetic pulse is being generated perpendicular to it. And on this animation, you'll see right now they're all aligned as to B0. And once we apply a B1 pulse, they're going to start to tilt at an angle and then precess like a top until it stops and it goes back to B0 direction again. So you'll see that precess. And that changes in vector actually produces the free induction decay signal. And this is our MRI signal as we know it. And that signal, as you see, decays through time. So that's a time domain signal. And we can say, how often does this happen through time? And actually Fourier transform it, FT, and then make it a frequency domain as you see it here. So this on the right-hand side is an MR spectroscopy spectra. And this is just a cartoon illustration of a spectra. It looks very, very beautiful here. This is an NAA peak. It's sort of a neuronal health metabolite in the brain. This is a creatine peak right here at 3 parts per million of frequency. And that is usually a indirect marker for brain energy levels. And then choline is sort of a marker for cell death sometimes. It's definitely a part of the cell membranes. This is a voxel, and so you can imagine taking a scoop of the brain and then laying out its chemical profiles on the spectra. This tallest peak is H2O, so it's not surprising that you have a lot of water content in the brain, and this is the largest peak itself. Now, how do we go from all these lines, these spectra, and how do we transfer that into a temperature reading? You can see that this H2O or water peak will move or shift towards these other metabolites if the brain is warm, and if the brain is cold, it's going to shift away from all the spectra. So the distance between this peak and the rest of the metabolite peaks gives you a good idea of what the temperature is in that part of the brain. So want to work to derive a calibration curve. We first heated up a bottle of metabolites that signified what a brain would look like. It's put it in a glass jar, and we mixed it with all these metabolites in good concentration. We heat it up to 50 degrees Celsius. We put on a MRI compatible temperature probe. Then we brought it into, we left the water, the heat outside, and then we brought the glass jar or our brain phantom into an MRI suite. We read the temperature readings so we know exactly what the temperature reading was. And then we scanned this phantom as the temperature dropped from 50 degrees to 25 degrees Celsius. And you can see here, this is a chemical shift on the x-axis, which is the distance between the water peak we saw and a NAA peak. And for every drop in temperature through time, it really follows, physics, and the association or relationship between that chemical shift and temperature is really tight. This is high fidelity at R squared of 0.99. And this is the equation for trying to derive brain temperature. This has been used in other NICUs. This was seen in pediatric research using our formula. I had good success with it in their unit, trying to derive brain temperature as well. So this is a sample MRI spectra data on the left-hand side. This is actually the same baby. Blue is during cooling, so this is a spectra obtained during cooling, and red spectra is during warming. You can see all the main metabolites actually don't move much. The other peak status, they overlap each other, but the water peaks move, and that's just a property of water. And once you know the distance between the water peak and a metabolite peak, you could come to this, formula or this ruler on the right-hand side, and then determine the brain temperature of that region. If anyone can guess, this is not a baby brain. It's very myelinated, and it's an adult brain. It's my brain back in, I think, 2013 maybe. This was the occipital parietal gray matter right here. This is my spectra, and there's, not noticeable lactate levels, but I have very good NAA levels. That shows me that my neuronal health is good. And then brain temperature back then was 37.1. That's one of the big limitations. We're taking a snapshot of the brain. We don't have a continuous measurement of brain temperature. And so we went on to design a study to study brain temperature when we have babies of HIE undergoing cooling. And so we wanted to take two temperature measurements, one during cooling and one during rewarming. This is Dr. Claire McLean, who's also here at Kaiser now, but she was my mentor back then and helped me carry out this experiment. They were all scanned in the same scanner, and the rectal temperature was also measured when we were acquiring the MR spectra. So we would know what the core body temperature was and what the brain temperature was. We measured brain temperature in 4 areas, as shown here. And then we transported babies through the NICU to the MR suite, continued cooling, of course, and there's no compromise in the treatment, and found a way to continue cooling inside an MRI with blank control extended. And then this just to show that their rectal temperature was kept within target measures during transport and an MRI. Okay, so this is the meat of the study. You can see we can start with the left-hand side. This is during cooling in blue. The rectal temperature was very, very tight at 33.3 in the moderate and severe patients. And the brain temperature average of 33.7, and then mean of 35.1. This was statistically different. So for the severe babies of HIE, they had a higher brain temperature despite rectal temperature being within target range. And this is similar as well, even after rewarming, that the brain temperature continued to be hot. I think what's interesting here is we could find a brain rectal temperature gradient, and this has been shown in pediatrics, traumatic brain injury, and adult stroke as well, that there is a brain rectal temperature gradient, and it's worse in those with severe brain injury. We went on to look at this in terms of MRI injury severity and at the SARNet staging, and we also found if you had severe injury, you tended to have high brain temperatures, sometimes 35, 36 degrees Celsius. On top of brain temperature, one of the other interesting studies we did was looking at brown fat. This is a Dixon scan, all these different images that you see on the left-hand side. It was used to measure fat in the liver, sort of hepatic steatosis, but you could measure brown fat as well in sort of the neck areas of infants. And it's interesting to see that after rewarming, the brown fat for these HIE infants are all depleted. So there is at least when we do cooling on HIE infants, you can imagine there is a metabolic compensation trying to rewarm the baby in some ways, and then the brown fat becomes depleted. Now, moving on to sort of the next question is, well, we know some parts of the brain temperature is hot, but are there regional differences? And, is this similar to a healthy primate brain? A lot of the animal studies show the core of the brain is much warmer than the periphery of the brain. And we wanted to test to see if that's true during cooling in an injured brain. There's some piglet studies. This is pre-therapeutic hypothermia, and this was done by Dr. Laptuk and Brown, and he's one of the, he's also measured a lot of brain temperature in infants as well. But before, the clinical trial for therapeutic hypothermia, he underwent there were some piglet studies that were done. You can see here that brain temperature actually was very close to rectal temperature. And then the core of the brain almost matched rectal temp. But there was a gradient with the scalp temp and dural temp. So the conclusion there was that the deep brain was slightly warmer than the superficial brain. This was replicated by Iwata in UK. As you cooled the whole body, as you cooled systemically from 38.5 to 32.5, you could see that the depth of temperature, this is 20 millimeters deep. It's warmer in the deeper parts of the brain. The problems with these two studies may be that they used a burr hole and then some wax in order to seal it. Not sure if that caused a change in temperature readings itself. But we went on to see if that was true. We looked at the distance between our voxels and the superficial part of the head, the cranium. And then we found that the thalamus was the deepest structure, followed by the basal ganglia. They're about 1 millimeter difference in depth, and then, 10 millimeters difference in 1 centimeter. And then the gray matter and the white matter were about the same depth. So you're going from 35 millimeters to, 30 and then 20 millimeters. But we found something that was reversed. The deepest structure was actually the coolest structure, followed by the white matter, which is more peripheral. And the deep structures actually match the rectal temperature as well. So this is in reverse of what we see in animals. So we think this really means there's effective cooling of deep structures by either blanket control or whatever device we're using to cool them from whole body standpoint. Or could this be more of a ischemic core penumbra effect where the core of the brain is dead or metabolically inactive, and you can see the spread of this injury with time. Could it be that metabolically inactive in the core of the brain, and hence less heat is being generated there? So back then the thought was, well, if we are pretty good at cooling the peripheral of the brain with head cooling, and then the core of the brain with whole body cooling, and we would do an augmented, actually combine both of them. But is this enough to impact outcome? And we want you to keep in mind that we did find a brain rectal temperature gradient, so maybe looking to see if rectal temp is even a good surrogate marker is an important thing before we move on to something like this. At the same time, in 2014, the optimizing cooling results came out. We can't really cool deeper or longer, so this is a 2x2 design where infants that had we can't say asphyxia, but who had low pHs, low GARs, were enrolled and then either randomized to standard cooling therapy or 32 degrees Celsius deeper cooling and longer cooling. And you can see that with each deeper, longer, and deeper and longer cooling, there was an increase in mortality. And hence this was closed early for safety and futility reasons. Deeper cooling was not a good thing to do. More nitric use, ECMO, more days of oxygen use, and higher incidence of bradycardia. So you can see some of the complications come out as we had longer and deeper cooling. This was also a very interesting cohort, though. If you look at this, mortality was only 6-7%. So this is lower than most of the modern cohorts. And so that study really illustrated that maybe we're hitting the sweet spot, 33.5 degrees Celsius for 72 hours, and if we modified that, we start tipping and having more of the complications instead of neuroprotection. So let's move on to at least illustrate some of the complications that can occur during cooling. And this was a study also done sort of to later parts of my fellowship, and as I came back for faculty. So this is a graph that shows sort of hemodynamic monitoring, pretty intense hemodynamic monitoring. We had serial echoes. We looked at serial MCA Dopplers, brain blood flow. We had cardiac output monitor that was continuously being generated, and then arterial blood pressure, heart rate, SATs, and then NIRS at the brain site and non-vital organ site. And the red is the cardiac output monitor. So you can see during cooling and as we rewarm, the cardiac output increases. And this coincides with the heart rate coming up in green. This kind of increases with time as you rewarm. The blue is a SAT monitor, so really remained well saturated throughout the cooling period. This is for one patient, mind you. And the brown is the brain SO2 or CRSO2. So you can say brain was oxygenating well, or it was getting good blood flow, which could still be luxury perfusion. And then the dark spots here are the renal side, so non-vital organ, and it's usually lower than brain. You can see it kind of mirror the mean blood pressure markings. So there's some association of that. One of our fellows was looking at that as well. So there were about 20 patients when we did this experiment, and this is, we see that during cooling, heart rate is low, and during rewarming, it increases. The study really just helps us understand when we do cool, what happens to a child hemodynamically. It's difficult to capture them while they're undergoing cooling initially, but it's easier when we're at the tail end of it and we can see what happens when temperature rises and derive what happens during cooling. The shortening fraction is also improved with rewarming, and then the stroke volume is unchanged. The cardiac output increases here, and when we use the electrical velocimetry method, and it's also increased when we use the echo method. So sort of confirming that these are the right findings, that there's higher cardiac output after rewarming and lower, of course, during cooling. The SVR is higher, more vasoconstricted during cooling, and then the mean blood pressure falls a little bit as we rewarm. This is what I wanted to point out with the brain versus non-vital organ oxygenation. So graph A is brain NIRS and graph B is renal NIRS. And you can see that if you do a ratio of that, normal ratios should be around 1 or 1.2. So you should have higher, more of that renal oxygenation, and then the brain should have less, but it's actually reversed. And this really signifies a diversion of blood flow from a non-vital organ to brain during cooling, and maybe periods of decreased cardiac output. And this is just sort of a summary of that. I'll skip this for now. The conclusion, we found that warmer brains were associated with more severe injuries and worse outcome, and that whole body cooling does effectively cool core structures. There's regional differences in brain temperature. Peripheral brain is greater than core brain temperature. Brown fat is depleted after whole body cooling, and that deeper therapeutic hypothermia starts to tip the balance from neuroprotection to more systemic complications. There is a brain temperature gradient, and so start to ask which is a better surrogate measure of brain temperature, or is there one? Is it esophageal temperature or is it rectal temperature? So the next part of the presentation hopefully just goes through some of the collaborations we've had and how through clinical trial design we're able to collaborate with each other and try to bridge knowledge gaps. We were part of the HEAL trial that largely had, largely showed that EPO did not improve outcome. These are all the collaborators, and 500 infants from 17 sites. And it showed that EPO really had no difference in primary outcome if you gave placebo versus EPO. This is a very high dose EPO, 1,000 units per kilo. So I think nobody's giving EPO these days, aside from maybe in a research setting or in a third world country, or in a low resource setting when cooling's not available. And so going back to this question of this brain rectal temperature gradient, what's a good surrogate marker? This was already shown that the esophageal temperature and the rectal temperature during cooling, this is by Sarkar et al. In Michigan, that he's already shown that there is a gap between esophageal and rectal temperature. And this is esophageal temperature tends to be higher than rectal temp. At his site, which is a Neonatal Research Network site, they exclusively cooled by esophageal temp. And I wanted to understand more, which site is the right site to cool. The 5 large randomized control trials, most of them cooled by rectal, and the NICHD or the NRN network would cool by esophageal.
Doctor, I think you're muted. We can't hear you.
Yeah. Do you have your? Oh, could you just unmute?
Oh, I don't know why I was muted. Okay, sorry. So this is a sample patient with dual core temperature monitoring using the Arctic Sun cooling device. This patient was cooled by esophageal temp. So you can see here that the esophageal temp was actually very tightly controlled. This is the one without the dot at 33.5. But the rectal temp starts to fall and sometimes goes down to 31 degrees. The blue curve is the water temperature. You can see that it falls to work to get the esophageal temp. The water temp falls in order to keep that esophageal temp low. But at the same time, you can see some of this mirroring that the rectal temp falls down as well. So that's, I think, where the complication occurs is you have a very nice fixed esophageal temp, but the rest of your body could be overcooled in that sense. And we see this for another patient as well, this temperature gap of about 1 to 2 degrees. So we looked at this, we cooled esophageally for about 20 patients, and then we cooled rectally for about 22 patients. But we monitored both temperatures. And you can see here, the esophageal temps here at 33.5 is very tightly controlled, but you're going down to about 32 degrees, and that's where you have more complications of cooling itself. And in the rectal group, you can see this is the brown rectal group at 33.5. And the esophageal temp is higher than the rectal group. So are we causing more systemic side effects of esophageal cooling? And are we undercooling or not providing enough cooling when we cool by rectal group? So use the HIE data set. So although it was a negative study for EPO, we found that in the 17 sites in that HIE trial, 9 cooled by esophageal monitoring and 8 would cool by rectal. 294 patients versus 206 patients. And since we have outcome measures and we have short-term outcome measures as well, we could kind of compare them and adjust for any sort of differences. Sorry, just a difference in esophageal versus rectal group among those 17 sites. It's very interesting that there are more intubations in the esophageal group. So not sure if it's a unit practice. They have a lower threshold to be intubating in the DR, but that came out to be different between the two cohorts. And then over here, there was just no difference in the primary outcomes. I don't think this was too surprising, but I'm glad that we're not undercooling anybody during rectal cooling. The 2-year outcome was no different. Complications of hypothermia, we do see that there's more overcooling when we do esophageal cooling. And we know that overcooling is probably not a good thing. And this is a forest plot looking at the different complications that could be associated with cooling itself. So it looks like there's more overcooling in the esophageal group, more hypotension needing therapy, and then more cardiovascular complications like bradycardia. So in all, this helps us conclude that we can cool either way. I think our 2-year outcomes are the same. However, there's seemingly more increased risk of overcooling and hypotension associated with esophageal temperature monitoring. Now, aside from how we perform, cooling, hypoxic ischemic injury can occur in different cell types within that neurovascular unit. How do the different cell types respond to cooling therapy itself? And this is sort of learning from adult stroke science. Dr. Patrick Leiden is an adult stroke expert. I think retired from Cedars and then now is at USC. And met him in Yokohama when we were presenting our brain temperature data. He's ran multiple clinical trials for adult stroke using therapeutic hypothermia, and none of that has worked. And so he's gone back to the bench and tried to understand why it doesn't work. He found that there are different types of brain cells, neurons versus glial cells, and they have different apoptosis and repair timelines. I just want to quickly show you this because I think that helps us understand how cooling works and how further monitoring, how further modulation might not help. So this is the neurovascular unit, neurons, astrocytes, and endothelial cells. They're subjected to a oxygen glucose deprivation of varying durations. And you can see that in the blue, this is the neurons, and red is the endothelial cells, and then in green is the astrocytes. Neurons die first. It takes only 2 hours of OGD or oxygen glucose deprivation to reach 80% cell death. This is cell viability. So you start 100%, and everything that falls is cell death. On the right-hand side, I think we can disregard it. LDH is just another surrogate marker for cell death. So you have increases in that. It just corresponds, kind of mirrors the graph on the left. Now, aside from subjecting the cells to different conditions, we also looked at the hypothermia, 2 hours of hypothermia, 6 hours of hypothermia, or 24 hours, duration of hypothermia itself, and the delay of starting it. So you can see that with longer hypothermia from 2 hours versus 24 hours, there's better neuronal rescue. We started with 100% cell viability, and with a day of cooling, it seems to preserve neurons. And if you delay it any longer from 0 to 60 minutes, you see that fall in cell viability. And then 33 is still superior to 35 degrees in terms of saving cells. This is neurons. Astrocytes actually show similar patterns as well. Improvement over 24 hours, and then better at 33. Endothelial cells don't really care. They seem to just do well with hypothermia itself. Compared to normal thermia here, there is a loss of endothelial cells. So this tells us that there are different responses to injury and to cooling itself. Now, astrocytes are known to be a very important component of this neurovascular unit. Is when you have neuronal injury, astrocytes are there to help repair, and go through the gliosis process. However, this is a very interesting experiment, seeing when you have astrocyte cultures undergoing OGD or hypoxia and lack of glucose, and then you cool them and you bring that medium into neuronal cultures that also undergo hypoxia ischemia. This tells you the effect of cooling astrocytes. And in normal thermia, without cooling astrocytes, you have really good neuronal cell viability. I think this is showing you that astrocytes, when they're normothermic, not subjected to 33 degrees Celsius, this conditioned medium can help repair and save cells. However, if astrocytes undergo hypothermia, you can see on the right-hand side, that neuroprotective effect of astrocytes is blunted. So, Dr. Lydon went on to try to propose, modulating therapeutic hypothermia by, maybe a very deep hypothermia at first for a few hours, and then going up to prevent astrocyte blunting of neuroprotection. Very complex. The biggest problem here is in adult stroke, we do know when the injury occurred. And in most of the HIE infants, we think it occurred around the time of birth, but that really might not be true. So this brings us to timing of injury. And I'll go through this quickly. I'm running out of time. But again, through collaborations, we could, this is published by Jessica Wisnowski at Children's LA. With the HEAL trial, there are multiple MRIs being done for the 500 infants. And we can define timing of injury as acute, subacute, chronic, or acute and subacute, depending on the diffusional changes from cytotoxic edema or the T1, T2 signal changes that occur later. And if you have volume loss and parenchymosis, then that is absorption of the cells. This happens chronically. And this just gives you an idea that, you have abnormalities in diffusional sequences followed by T1, T2 sequences later in the day, assuming injury occurred in time 0 here. And these are just showing you what acute injury looks like in terms of ADC changes, not so much T1, T2 changes. And a subacute injury where ADC is normal, but you have abnormal T1, T2 changes. And this is acute on subacute where you have both. Okay. We selected patients that had MRI, I think, within 7 days of life, because the later you do the MRIs, the harder it is for you to time injury, because that evolution has already occurred. you only might have T1, T2 changes. You never have caught the diffusional changes. So we try to restrict it to the first week of life. But ideally, if you wanted to time injury accurately, you really want it in the first 3 days of life. So for this study, we found that, from the HEAL trial, only 18% had acute injury, acute only injury. 19% had acute on subacute. So out of this modern cohort of HIE patients undergoing cooling, only about a third has some form of acute injury. Now, what about the mild HIE? So this is also a cohort from the HEAL trial that were cooled, but didn't enter the trial because it's mild HIE. Sorry, let me skip these real quick. This is, I think Sonia already spoke to you about mild HIE, so I'll skip a lot of this about mild HIE cooling. It's certainly a therapeutic drift where many of us are doing or cooling mild babies. And this is just to show you, there's a lot of children's hospitals also cooling mild HIEs. And the memory trial, this is a what I wanted to allude to is sort of the timing and pattern of MRI brain injury in the mild HIE patients. And so we did the same thing, with the HEAL trial, and then we tried to score their injuries. There's a big portion of 22% of watershed injuries, but also deep gray nuclei, which is surprising to us. And there's a high number of atypical lesions. And then a fifth of them had more than one injury. Looking at this, you can see acute injury here. About 32% had acute injury, and subacute was 37%. So more than 70% in mild HIE had either no injury or subacute injury. And these are recurrent trials. Cool Prime, which is occurring now, is a pragmatic trial. It's non-randomized. It's funded by Picori, and it's now with 16, 17 hospitals, including UK. And the mild HIE definition is having 1 to 2 abnormalities on SARNet. The COMET trial, so this is the one that the UK trial, it is randomized, and their definition is having at least 2 abnormalities, so a little bit more stringent. And a time trial, where that time study that Sonia Bonifacio has talked about, is a multi-center randomized controlled trial, and it also is more stringent, having 2 abnormalities. No results yet from them, but hopefully we could hear back from Sonia soon and give us more insight onto that. So last few slides, really just hopefully you could appreciate the complexity of the disease and how, there are parts of the brain that's resistant to cooling. There's a brain core temperature gradient. There's a difference in core temperature monitoring, and that the route of cooling actually affects short-term outcome. There's different cellular injury repair responses to cooling itself, the depth and duration of cooling. And then the nature of injury is different, in all these babies. It could be pattern, severity, and timing of injury, and that determines treatment direction and its efficacy. It's best if we could target and match injury repair timing. So with that being said, it's very complex and seems like there's really not much we can do to optimize, but comes new technology and sheds more light into, or more hope. Not sure if you're familiar with Hyperfine. It's a portable ultra low field MRI, and this is a brain temperature probe that you can place on the forehead. It's FDA approved and is shown to accurately measure brain temperature. At CHLA now, we're trying to actually validate this to see if it's true, if it's usable, and this will give you continuous brain temperature monitoring. So this is me with the same shirt and the same tie, but in that portable MRI unit, and within about 15 minutes, this is my brain on the right-hand side. You can get diffusional scans as well. And this is comparable to a 1.5 T. So ultra low field, no need for shielding, and you can get beautiful images quickly. So that to me is very exciting, and potentially could be a proposal of how we treat. If we're able to phenotype HIE patients for individualized treatment, initially with a early swoop MRI or hyperfine low field MRI, these could be pushed to a patient room and have it scanned without needing to shield any sort of metal objects. You could have IV poles and all of that right next to it. If there's diffusional problems, then you go down the route of therapeutic hypothermia, because diffusional abnormalities really speak to acute ischemic injury, cytotoxic edema. So you could go into cooling, and then, if it's acute injury, acute subacute pattern of injury, then you could think about either targeting the oligodendrocytes or the neurons. If there's no diffusional abnormality, which we see in maybe a third to half of these patients, then this is subacute and chronic. Then cooling may really interfere with the repair process theoretically, and so we might undergo a different pathway to combat gliosis, chronic inflammation, and induce neuroplasticity. That's a lot being said and a lot of work to be done. So in conclusion, complex disease HIE is I think there are still opportunities to optimize cooling itself. The most important thing is really to know what we're dealing with. If we could categorize these patients based off injury phenotype instead of just cooling all of them from our clinical markers. And then hopefully we can hear from Sonia soon about critical care management of these patients to achieve that fine balance between neuroprotection and the systemic complications of cooling itself. Acknowledgement slide for everyone that's helped me go through the brain temperature research. It's been quite a thankful to the families as well, quite a journey. And now, of course, to the nursing and RT staff that's gone down to MRIs with me very, very frequently. Thank you.
So while we wait for questions to roll in, can I first acknowledge, oh, you're getting a lot of claps here. Can I first acknowledge how close Tai is to Yoda? He said, complex disease HIE is. Yes, it is. Also, I want to thank you for your dedication to research by using yourself as a study participant and control. We've got one question first here about the esophageal versus rectal cooling. What was the definition of overcooling? Was it less than 33 degrees? And thank you. That is from Nidhi Shah, who is our neuro NICU champion here in Orange County.
Yes, that's right. It is less than 33.0.
33.0. Okay.
Yep.
And go ahead and either unmute yourselves or put your, oh, maybe I've got some new ones here about any other questions. So in our facility, at least in Southern California, Kaiser, we've opted for esophageal cooling, in Orange County. That is, we're one of 3. Are there any tips or tricks or signs that you have found, at least in your studies, that maybe we should remember early on in our management with this risk of the possibility of overcooling systemically?
Yeah, I think the positioning of that esophageal probe is always sometimes a problem. Babies may gag if they're more active, may start to come out. I think Downey also cools by esophageal probe as well. I was there just last week and we had a cooling patient there. There's no good way. I mean, it seems to be how the Arctic Sun or how your blanket control machine is there to react to changes. And I think it overreacts and it overcools. You can see the water temperature drop drastically trying to lower that esophageal temperature, and I think it overshoots. And then you'll see that rectal temperature actually drop if you have 2 temperatures being monitored at the same time. And I just imagine if you had a PPHN baby and now your rectal temp is down at 30 degrees, that may interfere with pulmonary hypertension itself. The complication side, we didn't see any more sort of increased nitric use or ECMO use in the esophageal side. But I think, it really does have short-term complications in terms of hypotension and overcooling. Why not do rectal?
That's a great question.
It is very simple. It is very simple, and you don't need X-rays to keep looking at and keep adjusting your esophageal probe. I think a lot of the neonatal research network has kept to esophageal because it's been culturally so. I spoke to Dr. Laptuk about this as well, but I think more sites are moving to rectal because of the ease of application.
Yeah, and if it is, the 2-year outcomes, keeping our eye on the prize, if the end game seems to be, no different or very similar, then that might be a thing. We've got a comment here that the rectal probe is easy and less invasive. So someone cheering for that.
Yeah. I mean, there's some thought about the rectal probe being more stable in temperature profile. You'll see that it doesn't swing as much. I have a USC student actually working on this right now, looking at the gradient of esophageal and rectal temperatures. When we gap, what happens to our blood pressure? What happens to NIRS measurements as well? And we found there is hemodynamic association when those temperatures gap. And so it does cause some hemodynamic effects. And I think that's the water temperature effect. The reason the rectal temps might be more stable might be the meconium that wraps around the probe itself as a little bit of a buffer. Yeah.
Sticky.
Yeah.
Yeah. I wanted to ask you a question about that amazing, real time or quick MRI situation, and helping it be more precise in which patients may be more apt to cooling versus not. Since we don't have that capability now, and we're the soonest we could get the MRIs, maybe 3 to 7 days. How could this help in our conversations with parents, and what particularly should we ask our neuroradiologists to perhaps say or help us along with to give us that sign that this was a subacute or chronic situation, and maybe that might be helpful and or otherwise. Yeah.
Always helpful. I think, unfortunately, MRI might be one of the most important, often used in medical legal cases as well in terms of timing. If you get your MRI, 9-10 days out, you're out of the window for any sorts of fusional changes. And so no longer can you time and say this is subacute or acute. Getting it at 3 to 5 days would be helpful, but sometimes patients are not stable to go and you just don't have timing then. That portable machine is actually quite cheap. I think it's around $200,000-300,000 compared to an MRI machine in the millions of dollars. So it is still is FDA approved, but still research based in many of the children's hospitals right now. Certainly, I don't expect us to get portable MRIs now, but I think that would be the trend in the future, is not cooling them immediately, but actually seeing their brain and the fusional changes, sort of like acute stroke, seeing what's really happening. And so, yeah, it's hard to comment on what should we talk to the radiologist about, but the fusional changes versus T1 and T2 changes could be helpful in timing of injury.
I think maybe that.
And
would
I'm
be
happy
the
to help whoever. If I may review cases, I'm happy to help and email away or just call me. And happy to be part of this family now and can help with navigating that interpretation.
Excellent. That's so everybody heard that. It's HIE is happy to help. Thank you. Yeah. We've got another question here about, as we wait for more data regarding to cool mild HIE, what are your just overall thoughts on it?
Oh, I think there's equipoise now in the community. We don't know what to do, and hence, can do trials. However, if you were to cool a mild HIE baby now and you document all over your chart mild HIE, I think you still need to really also document consent from the parents, or at least permission from the parents that you've discussed it. This is out of the ordinary that we cool. That would help you. As you know, other trials now have shown maybe cooling preterm babies is not a good thing. We've cooled down to 35, 34 sometimes out of protocol too. Those we really need to document as well. I think more of the NRN data is coming out to show more problems with cooling preterm babies. Now, same thing with mild HIE. You just don't want to be in that situation. You're trying to do something good to help patients, but then 3 years down the road, when Cool Prime, Comet, and Time Study comes out and says there's more injury, there's worse outcome, then I think that'd be a problem.
Yeah, so it sounds like a very careful line we've got to walk there.
Yeah, if you think the baby has mild, I wouldn't cool. And if you really wanted to cool because you believed in mild HIE cooling, I'd really recommend talking to the parents and documenting so that we don't know the efficacy of it.
Yeah, and clear documentation for any of these cases is so important, part of the legal package that the medical record is. See, I did a Yoda there too. Another question, how do you recommend documenting? Do you recommend labeling HIE in the problem list, neonatal encephalopathy, or any other? Are there any issues from a legal perspective?
Yeah, that's a great point. I think we should all be saying encephalopathy, neonatal encephalopathy, until later. I mean, you're presuming this is HIE, but you don't have confirmation. You have inkling from the clinical side that you have low pHs. There's an ischemic process, but did it affect the brain? We don't know. So I would say keep it neonatal encephalopathy, or say presumed.
I don't know why it's not turning up.
Oops, we got here we go. I got it.
Yeah. And that's sort of the recommendation from the academic communities as well right now is I think even when you try to publish saying HIE, they don't like that term because you don't know it's HIE until later. But once your MRI does show diffusional changes and injury that's compatible and congruent with HIE, then you can put that into charting.
So just for like a curious and clarifying question, so then if we don't have that on MRI, any evidence of HIE on MRI, we should probably stick with neonatal encephalopathy. Does that sound correct?
Yeah, and undergoing therapeutic hypothermia for presumed or suspected HIE. Yeah, you still use the suspected HIE based on clinical factors. It's okay.
Perfect.
But I think from a medical legal side, it puts our OB colleagues at a difficult state when we start off with that.
Yes.
A lot, as the HEAL trial has shown, a few percent does have stroke. They're not HIE, and some of them are septic. So not everything is HIE.
And we're at time for the hour, but I want to invite anyone else who has questions to chat it in. Otherwise, I'll give a big round of thank you to Dr. Wu. As I said in the chat, we've got Sonia Bonifacio coming in for a follow-up on like a deep dive of clinical management during therapeutic hypothermia. And next month, we'll come back again on the third Tuesday. We will be talking about chest compressions for acute issues of resuscitation and decompensation. Third Tuesday of the month in December. Thank you so much, Tai. We're really lucky to have you.
Thanks for having me.
We couldn't be more grateful. I mean, to have you in Southern California, we couldn't be more grateful to have you as a resource. So we really appreciate that.
Excited to be here. Excited. Beyond excitement. It's been great past 3 months.
It has, right? I mean, sorry. Me too. I've only been here 3 years, but I think it's fantastic. I just absolutely